Good morning, everyone. I'm going to be talking about seborrheic keratosis. This is one of the common conditions that we encounter in our dermatology department. And these are the most common benign epithelial tumors of humanity with an increasing incidence with age. Seborrhea basically means disease of the sebaceous glands or discharge of sebaceous matter. It is coined from both Greek and Latin. Latin, the word sebum, which means literally tallow, sweat, or grease, and Greek, the word rhea, which means rein to flow. Now, these lesions are primarily benign and they are highly biopsied and typically removed for cosmetic reasons. A frequent focus of patient concern because of its variable appearance, and despite their higher prevalence and large cost burden, seborrheic keratosis are not widely discussed in the current literature. Now, coming to the pathogenesis of the condition, it's entirely not understood, and there are certain risk factors that are associated with the development of these conditions. For example, UV exposure. As we know, UV exposure is known to cause severe skin damage. It damages the DNA. Here, we have found out that it has been implicated in the etiology of seborrheic keratosis. An Australian study found more frequent, flatter, and larger lesions in sun exposed body sites, as well as higher seborrheic keratosis prevalence when compared to other Caucasian populations in the United Kingdom. A survey of 840 people in China also found a relationship between cumulative UV exposure and seborrheic keratosis, noting that residents of Fitzpatrick 2 skin types were susceptible to more severe photoaging than those with Fitzpatrick 3 or 4. Now, age is also a widely acknowledged risk factor for seborrheic keratosis. Amyloid precursor protein, which plays an important role in the pathogenesis of age-related Alzheimer's disease, was recently shown to be elevated in seborrheic keratosis tissues as compared to the control. This is from a study that was conducted as mentioned below. The expression levels were particularly high in UV-exposed areas and the older age group between 61 to 85 years, though a positive age-related correlation was found in the epidermis but not the dermis. Guanine deaminase upregulation in seborrheic keratosis has also been implicated in the UV-induced keratinocyte senescence, where the production of uric acid generates reactive oxygen species and damages DNA. Immune factors are newly implicated in the formation of seborrheic keratosis, and mast cells have to be seen significantly increased at the periphery of seborrheic keratosis tumors, and mast cells, stem cell factors, and cannabinoid receptor type 1 are differentially expressed within them. This novel mechanism suggests that immune components involved in inflammatory dermatosis may also play a role in seborrheic keratosis pathogenesis. Now, despite their benign nature, a large proportion of seborrheic keratosis exhibit oncogenic mutations. A somatic mutation in fibroblast growth factor receptor 3, identical to those associated with skeletal dysplasia and urogenital neoplasms, is correlated with age and body site in seborrheic keratosis patients. In recent years, additional oncogenic mutations have been elucidated. For example, studies have found that the FGFR3 mutation was the most frequent detected in 48% of the lesions, followed by the phosphatidyl inositol 3 kinase mutation, 32%, the telomerase reverse transcriptase promoter mutation, 24%, and the diphthomide biosynthesis 3 promoter mutations in 24% of the cases. This is just a pictorial description of the pathogenesis that I explained earlier. As you can see, UV exposure, the overproduction of amyloid precursor protein. Then we have the mutations that happen, even the guanine deaminase upregulation, immune or inflammatory mechanisms, all of this eventually leading to formation of seborrheic keratosis. Now, coming to the epidemiology, it has been seen to occur in middle aged individuals, and the peak incidence of seborrheic keratosis is said to be between 31 to 50 years of age. Gender distribution of seborrheic keratosis is balanced, and in some studies, a slight female preponderance was seen. Before I go into explaining the clinical features of seborrheic keratosis, I just want to explain or give you all just a brief outline of the skin once again. These are the layers of the skin. So basically, we have three layers: the epidermis, the dermis, and the subcutaneous layer. Now, the epidermis is divided into four layers on all parts of the body except the palms and soles, where we have five layers. So, starting from top below, we have the stratum corneum, stratum granulosum, stratum spinosum, and stratum basale. While on the palms and soles, in between the corneum and the granulosum, we have a layer called as the stratum lucidum. It's not there in this picture. Now, in the dermis, we have all your collagen fibers, elastin fibers, we have the hair follicles, we have the erector pili muscle, which is responsible for the goosebumps, we have the sweat glands, and we have the sebaceous glands. The last is the subcutaneous tissue. Now, coming to the clinical presentation with the histology, there are different types of seborrheic keratosis. I'm going to be explaining all of them. First, we have the hyperkeratotic type. Now, the histological feature of this common subtype is orthohyperkeratosis with papillomatosis. Acanthosis is mild or absent, and horn pearls are missing. Acanthosis basically means thickening of the stratum spinosum layer, so that's not seen. Um, Coming to acanthotic seborrheic keratosis, here we have the most common subtype. The tumors are characterized by huge acanthosis but mild or missing hyperkeratosis and papillomatosis. Horny invaginations that on cross sections appear as pseudo-horn cysts are numerous. True horn cysts are also seen, which shows sudden and complete keratinization with a very thin granular layer surrounding it. Just coming to the histopathology of this. So as you can see, there are pseudo-horn cysts and there are horn cysts. Now, what horn cysts are? They are a foci, an isolated foci of orthokeratotic cells. That means normal-looking keratinocytes are there, and that's an isolated foci of it. Now, the pseudo-horn cysts basically mean that they are pushed up into the papillomatosis is more increased, and it pushes it up towards the cervix. Reticular or adenoid type, this subtype is characterized by reticular acanthosis of thin double row with mild to moderate hyperkeratosis and papillomatosis. These seborrheic keratoses are often hyperpigmented and horn pearls are uncommon. This subtype is more common in sun-exposed areas. Now, coming to the clonal type, in this type, marked acanthosis and papillomatosis are associated with orthohyperkeratosis. Now, these lesions also need to be differentiated from genital warts, and the way we do this is either by biopsy or by immunohistochemistry. Now, the irritated type, a proliferation of spindle-shaped eosinophilic tumor cells is found, sometimes in whorl-like formations, and dyskeratotic cells may be present. Melanoacanthoma, this is the hyperpigmented acanthotic type with the proliferation of basaloid cells with mild or even absent hyperkeratosis. Numerous melanocytes are intermingled and the melanophages are located within the dermis underneath the tumor. Dermatosis papilosa nigra. These are multiple small 1 to 5 millimeter diameter smooth firm black or dark brown papules on the face and neck, and the histology shows a seborrheic keratosis with markedly increased pigmentation of the basal layer of the epidermis. Stuccokeratosis, flat-topped keratotic papules with a stuck-on appearance on the skin like sprayed chalk or stucco cement. Now, there is something very important with seborrheic keratosis. Those are the types, but there is something called as the sign of Lesser Trelat. Now, the sign of Lesser Trelat is a skin disorder characterized by the abrupt appearance of multiple seborrheic keratoses that rapidly increase in their size and number. It is caused by an associated cancer and often occurs with malignant acanthosis nigricans. The sign of Lesser Trelat has been linked to a variety of cancer, but it is mostly associated with adenocarcinoma of the stomach or colon. Other cancers where the condition has occurred include squamous cell carcinoma, lymphoma, and leukemia. They appear as brown, warty nodules with a stuck-on appearance. Now, the key three indicators to determining a diagnosis are the sudden development of seborrheic keratosis that increase in size and number over a very short period of time. Accompanying signs and symptoms of malignant acanthosis nigricans occurs in as many as 35% of cases. Appearance of eruptive seborrheic keratosis in individuals aged less than 30 years. Now, pruritus itching may be the only symptom of the sign of Lesser Trelat and occurs in almost one half of the patients. Now, this is the typical picture of the sign of Lesser Trelat. As you can see, the multiple hyperpigmented or brown papules stuck on the back with sudden onset or eruption in this individual. Now, there is something called as the pseudo-Lesser Trelat sign. This is the inflammation of pre-existing seborrheic keratosis during chemotherapy of malignancies using drugs such as cytarabine, docetaxel, gemcitabine, or PD-1 inhibitors like nivolumab. It can be associated with burning and pruritus, and the tumor therapy can be continued. When we come to the diagnosis, Dermoscopy is a good way to identify these lesions because these lesions not always look benign. Sometimes we are confused with other kinds of tumors or we are confused with other kinds of skin lesions. So, what we see on dermoscopy are, as you can see in the picture, melia like cysts that are small, whitish, firm papule like appearance. Then we see fissures and ridges. We see hairpin blood vessels surrounded by whitish halo, network like structures, fingerprint like structures, and comedor like openings. On a biopsy, what we see is, as I mentioned earlier, we see acanthosis, pigmentation, horn cyst formation, hyperkeratosis, papillomatosis, and pseudocysts and true cysts. Both are seen depending on the kind of seborrheic keratosis we get. Now, there are other diagnosing techniques such as reflectance confocal microscopy, where this visualizes the epidermis and superficial dermis at a cellular level. Seborrheic keratosis specific features include epidermal projections, keratin filled invaginations, cords and bulbous projections, corneal pseudocysts, and a mixed vascular pattern. As you can see in the picture on the left and right, if they've pointed an arrow at the 1 o'clock position, you can see that's the same comedone like feature that they're showing, and in the bottom, the melia like cyst at the bottom 7 o'clock corner. Now, with modern times, artificial intelligence is also playing a big role. And what is happening is there have been studies done where seborrheic keratosis images are often used to train AI based algorithms capable of distinguishing malignant skin tumors from benign mimics. When we come to the treatment, the main reason why the patient comes for treatment is either because of a cosmetic concern or because the patient wants to rule out any malignancy. So, patients have wide range of motivations for treating or removing seborrheic keratosis, including embarrassment from the stigmatizing appearance of the lesion, physical irritation or pruritus, and a desire to look younger. Lesions that are inflamed, bleeding, ulcerated, or sufficiently irritated should be further characterized by a biopsy or excision to rule out malignancies. The clinical response was graded using the physician's lesion assessment. 0 meaning it's completely clear, 1 is near clear, 2 is less than or equal to 1 millimeter thick, 3 is more than 1 millimeter thick. This is all after treatment. Now, coming to topicals, what we use, there are many things that we can use, but some of the things that I'm going to mention here are nitric zinc solutions. So, this is a topical solution formulation in an aqueous solution containing nitric acid, zinc, and copper salts, and organic acids such as acetic, lactic, and oxalic acid. Treatment consisted of the topical application to obtain a whitening yellowish reaction on top of the seborrheic keratosis. Another product used is trichloroacetic acid and formic acid, which similarly showed complete response in 90% of the patients, but was associated with more drug related adverse events. Focal TCA plates were also shown to show good clinical response in darker skinned people, Fitzpatrick type 4 and 5. Studies have shown tazarotene 0.1% cream improved outcomes in some patients. Tazarotene is a third generation retinoid, and a 12% ammonium lactate solution, lachydrin, also affected certain elevated lesions. Topical 5% imiquimod cream and 3% diclofenac gel has also been reported to show some sort of effect. However, I personally noticed that imiquimod really doesn't do much, and diclofenac I've never tried, so I don't know. Cryotherapy, the tendency for hypopigmented scar formation is greater than with 12 months of curettage. So, what happens is cryotherapy, we use liquid nitrogen minus 196 degrees Celsius. Of course, the side effect of using it is after the procedure is done, when the patient heals, it leaves behind an area of hypopigmentation, which is harder to treat than the actual seborrheic keratosis itself. Surgical excision or curettage, which is my personal favorite, is the best way to go about this. And lasers are also done, ablative laser therapies like carbon dioxide laser, but with a higher risk of scarring and pigmentary changes. Non ablative laser therapies have also been reported. Nd:YAG lasers at 1064 nanometer, Q switched, intense pulse laser are also used. This is just a summary of all the topical therapies and the liquid nitrogen cryotherapy. So, what is our take home message? Seborrheic keratosis is a benign condition, and what we need to do is observe for abrupt changes or for the sign of lesser Trelat. We need to explain the treatment modalities and the associated side effects to the patients. And if in doubt, we definitely need to do a biopsy just to make sure that the patient is completely fine or the lesion is completely fine. These are my references. Thank you.